So, good afternoon po. Ako po si Dr. Generoso Roberto, GR po for short. Ako po ay isang membro sa Philippine Society of Public Health Physicians. So, for the past week po, ang PSPHP ay nagsasagawa ng mga Zoom lectures para po matulungan yung ating mga kasama, mga health workers, especially sa mga provincial, and other local government units para matulungan po sila to capacitate them para po mas lalong ma-address itong COVID-19 pandemic na natin. So, ulitin ko po, general rule lang po is first, pa-edit po yung ating mga pangalan para po malagay yung institution po kung saan tayo galing para po for documentation purposes. Tapos po kung later on sa ating lecture, kung meron po tayong mga tanong, pwede po nating i-chat po muna and later on after po nilang matapos, we could isa-isahin po natin. Now, katulad po sabi ko, ilang weeks na po na ginagawa ng PSPHP itong lecture series. And for this day, feel ko po napaka-up ng ating topic po for today, Biosafety 101 for LGUs. Lalong-lalo na unang-una, nagra-ramp up na po tayo for testing. So marami na po tayong mga LGUs na nag-initiate, na gumawa ng mga laboratories, magpa-accredit ng mga laboratories para mas masagawa yung testing po na ito. And also, yung ating may mga questions or mga regarding sa mga PPEs. So this lecture is an opportunity to learn more on how natin mami-minimize yung risk ng ating mga health workers and laboratory workers. So for today, we have 3 lecturers. Sir Edsel Salonga of the UP National Institute of Health. He will talk about biorisk management, and also Dr. Jaifred Lopez. He's a professor in the Department of Nutrition, the UP College of Public Health, and also a member of PSPHP. And Ma'am Kim Sales of the Alliance of Improving Health Outcomes. They would talk about their research regarding the development of the Philippine biosafety and security framework. So without further ado, I'll now call on our first lecturer, Sir Edsel Salonga. Sir?
Good afternoon. So I'm Edsel Salonga. I'm from the Institute of Human Genetics, National Institutes of Health, UP Manila. So I'm representing the National Training Center for Biosafety and Biosecurity. And my topic for today is Biosafety 101 for the LGUs. So in today's session, I will be discussing Biosafety 101. So as you know, sa ating current events, COVID-19 is now an official pandemic. And an important part of mitigation for the pandemic is lab testing for the SARS-CoV-2 virus. But without proper biosafety measures implemented in a laboratory, accreditations of these laboratories testing for COVID-19 is being hindered. So as you know, RITM is the only WHO accredited national laboratory testing for COVID-19 here in the Philippines. They have accredited around 7 subnational laboratories, including our institution, the NIH. So why build biocontainment laboratories and institute biosafety practices? So we have 3 purposes. So one is to protect the laboratory staff by preventing laboratory-acquired infection. Second is to prevent secondary infections in the community. And third is to prevent environmental or animal population containment. So in terms of biosafety for the third part, pwede na rin siyang i-consider as a biosecurity aspect. So what is biosafety? Laboratory biosafety are measures employed when handling biohazardous materials to avoid contamination of oneself, others, or the environment. While laboratory biosecurity are measures employed to protect biohazardous materials or critical informations against theft or diversions by those who intend to pursue bioterrorism or intentional misuse. Sorry. So the guidelines we are using now is from the CWA 15793, Laboratory Biorisk Management. Other guidelines are the ISO 35001, 2019. So this is the version of the ISO for the CWA 15793. And the tried and tested BMBL, issued by the WHO and CDC. WHO likewise have its own laboratory biosafety manuals, and WHO, CDC, and RITM, and also in DOH had released interim biosafety guidelines for handling SARS-CoV-2 virus. So why do we need to have biosafety? So without biosafety, in the beginning, when there was no biosafety, nung nag-uumpisa pa lang yung mga laboratories, so wala pang available na mga PPEs, ng mga engineering controls, o mga best practices, madalas magkaroon ng acquired infections sa laboratories caused by human factor and equipment failure. Tapos, ang mga top accidents is usually yung mga accidental spillages or splashes, needle pricks, sharp objects or broken glass, and dun sa mga research involving animals, bite or scratches from the animals and ectoparasites. So what is biorisk management? Simply put, this is a management system that is risk-based, um, surrounding risk involving biosafety and biosecurity. So when we say biosafety and biosecurity, it equates to all the risks related with the laboratory hazards present inside the laboratory. So biosafety plus biosecurity would mean biorisk management. Biorisk management system is a system that is meant to reduce biorisk in the laboratory. So how do you implement biorisk management? So we use a simple tool. We call the model as AMP model. So the AMP stands for Assessment, Mitigation, and Performance. So for those ISO accredited organizations or institutions, this is the equivalent to PDAC or the Plan, Do, Check Act of the ISO. So for the assessment, this is analyzing a particular situation to determine the likelihood and consequence of a certain adverse effect. Ang components niya is risk identification, risk characterization, and risk evaluation. For risk identification, you need to identify the hazards first. And in our case, for biosafety, most of the hazards are the pathogens. So for the pathogens, we have for chemicals, we have what you call the MSDS or Material Safety Data Sheet. So for the pathogens, we have the PSDS or the Pathogen Safety Data Sheet. So once you identify the hazard and the risk involved, you characterize the risk through the likelihood of or probability of it occurring, and the severity of the consequence of that particular event happening. Then after characterization comes the evaluation. Is the risk acceptable or is not? If not acceptable, you should be performing risk mitigation until the risk is low enough that it is acceptable. Then you can proceed with the activity. So for risk identification, when you use the pathogen safety data sheets, to make it more easier, um, CDC or the US NIH have come up with a risk grouping of the different pathogens or organisms. So risk group 1 includes pathogens or microorganisms that has low individual risk or community risk. So usually, itong mga risk group number 1, ito yung mga nakikita natin sa mga educational institution. So sa mga teaching lab, yung mga ginagamit nilang mga microorganism doon, like E. coli. Risk group 2, moderate individual risk or low community risk. So meron ng pwede na ma-infect ng microorganism yung mga persons handling the organism. Pero ang important dito sa risk group number 2, to moderate lang yung consequence, tsaka merong available treatment or prophylaxis yung pathogen. Sa risk group number 3, high individual risk but low community risk. So dito, serious na yung human disease pagka na-infect ka ng microorganism. Possible may treatment pa rin, pero wala siyang, hindi mataas yung transmission niya sa community. So example siguro nito is yung MTB. Yun yung magandang example niya. So highly infectious, high yung individual risk, pero meron siyang treatment available and low yung transmission niya sa community. Then risk group 4, ito na yung highest risk group. So nandito yung high individual risk saka high community risk. Sa individual, nandito na yung pagka na-infect ka, may possibility na serious physical injury or even death. Saka highly transmissible siya sa community. Walang effective treatment or prophylaxis na available. So, a good example would be Ebola. So that's a good example for risk group number 4. So in risk identification, so katulad ng nasabi ko, gumagamit kami ng pathogen safety data sheets. So there are different biosafety organizations throughout the international community. So meron yung US, yung American Biological Safety Association or yung ABSA. Yung counterpart niya sa Europe is yung EBSA. Tapos meron ding Canadian Biosafety Standards, Australia at New Zealand meron din. Germany meron din. So may kanya-kanyang pathogen safety data sheets, pero usually ang ginagamit namin is yung sa Amerika at sa Canadian. Yung Canadian, ang magandang ginawa ng Canadian, gumawa sila ng app for Android and iOS. So search nyo mamaya sa mga phones nyo or right now sa App Store, type nyo lang yung PSDS or Pathogen Safety Data Sheets. So dun sa PSDS, once na na-download nyo na, mabibigay na sa inyo ang mga different information about the pathogen. Yung kanyang virulence, transmissibility, disinfection, containment level, risk grouping, available treatment, how to handle, how to dispose of properly, yung viability ng pathogen sa environment. So any information, basta napag-aralan na yung virus, naka-enter na siya dun sa pathogen safety data sheet. And And upon that, hazard identification, makakarakterize na natin yung pathogen. So ang pinaka-important siguro dito is yung route ng transmission of the pathogen. So sa humans, meron tayong around 5 transmission routes. I think nasa further down sa lecture yung transmissibility. So next is the characterization. So ito yung sinasabi kong routes ng pathogen. So pwedeng pumasok siya sa mucous membrane, respiratory tract, sa lungs, through inhalation, gastrointestinal tract through ingestion, skin or percutaneous to needle prick. Parang may isang hindi na isama dito. So mucous membrane. So sa characterization, kung alam na natin yung route of transmission, makakarakterize na natin yung likelihood kung ma-expose ba yung end user or yung environment natin or pati yung community. Ano ba yung mga vectors ng mga pathogens na to? So after ma-characterize yung likelihood, titingnan naman natin yung consequence. Ano bang severity ng harm na makokos niya kapag ka na-infect na yung staff or yung end user. So masasabi natin na yung risk characterization is characterizing the likelihood and consequences of that particular pathogen. Then after risk characterization, ma-evaluate na natin kung acceptable ba yung risk or hindi. We now go to mitigation kung hindi acceptable yung risk. So we have 5 methods of mitigation for biosafety. So first is the elimination or substitution. Next are the engineering controls. Next is the administrative controls, practices and procedures. And lastly is the personal protective equipment, which controversial right now kasi nagkakaroon ng shortage sa PPE. So dun sa una, mitigation is elimination or substitution. An example nito is, ito yung kung glass ang gagamitin mong equipment, prone siya sa breakage. So magkakaroon ka ng broken glasses. Kung isa-substitute mo siya ng mga plastic containers na same din naman yung intent or purpose, marireduce mo yung risk ng injury to broken glasses. So kung elimination, completely tatanggalin mo yung hazard. Kaya lang sa case natin, pagka tinanggal mo yung hazard, wala na tayong pathogen na pag-aaralan. So hindi usually convenient sa atin yung elimination. So substitution, pwede. Another form of substitution is kung kunwari, nag-aaral, may study ka about, research about Bacillus anthracis. Kailangan gumamit ng experiment mo ng anthracis, pero pwede mo bang i-substitute yung anthracis sa subtilis para less pathogenic siya? So yun yung example of substitution. So for the engineering controls, so ito yung mga most effective na mitigation controls that involves placing a barrier between the user and the pathogen. So the most efficient of them all is the biosafety cabinet shown here in the picture. Then you have your centrifuges with containment leads, or what you call the bio-leads, and having puncture-resistant containers for your needles and sharps. So dito sa slide na to, pinapakita yung mga different levels of biosafety containment. Meron tayong 4 different levels. So for biosafety level 1, so yan yung mga example ng teaching lab natin. Usually mga benches lang, tsaka minimal PPE like gowns, gloves, tsaka mask. For biosafety level 2, lahat ng containment principles tsaka practices mula sa Biosafety Level 1 plus dito required na magkaroon ng hand washing facility, then autoclave, then pwede na rin desirable lang sa kanya ang biosafety cabinet depende sa organisms na hinahandle ng laboratory. So sa biosafety level 3, meron ng additional control for aerosol. So yung buong room, hindi lang yung biosafety cabinet, HEPA filtered na. So for HEPA filtration, ang ibig sabihin ng HEPA is high efficiency purified air. So dumadaan siya sa isang HEPA filter. Pagka dumaan siya doon, napi-filter na yung mga microorganism. Usually mga bacteria, viruses, and fungi. Effective siya. And then sa biosafety level 3, mag-umpisa na rin maglagay ng ano tawag dito sa entrance? May mental block ako. Hindi ko matandaan kung ano tawag dun sa entrance before sa door ng actual laboratory. Baka matandaan ko mamaya. Then, sa biosafety level 4, highest form of containment, nandito na yung super containment natin. So, sa entry pa lang, marami ng control sa pagpasok pa lang. Hindi katulad dito sa biosafety level 3, isang door lang. Dito, multiple doors para pagbukas mo ng isang door, hindi nagmo-move yung air sa susunod na room before ka pumasok sa actual laboratory. Then, yung mga highest PPE, dito na rin ginagamit in conjunction with the biosafety cabinet. Meron na rin mga malalaking autoclaves or yung mga autoclaves na pwedeng ilagay sa walls. Meron na rin mga pass-through box para hindi dumadaan magkasama yung stop tsaka yung sample. And then ang pinakamahalaga, so ni-represent lang na maliit dito. So nakikita nyo sa taas, nandito yung mga ventilation or mga ducting ng biosafety cabinet tsaka ng buong room. HEPA-filtered lahat yan. And then dito sa baba, nakikita nyo yung mga gases na nagsusupply, yung mga vacuum, tsaka yung effluent system. So sa effluent system, nandito yung mga drainage or yung mga liquid waste natin. So dinidecontaminate bago pumunta sa regular sewer. So highest level of protection yung biosafety level 4. So sa Wuhan, ayun sinasabi na kung saan nag-originate yung SARS-CoV-2, meron silang biosafety level 4 laboratory na nag-fuel na sa mga rumors na bioengineered yung SARS-CoV-2 kasi nandun located coincidentally yung BSL-4 facility ng nag-iisang BSL-4 facility ng China. Then ano ba yung difference ng biosafety cabinet versus laminar hood? So sa laminar hood, HEPA filter din siya. So makikita nyo sa illustration, yung flow ng air is laminar or in one direction, tapos hindi sila nagsasala-sala or walang turbulence sa loob ng cabinet, which is good for preventing cross-contamination. Sa regular fume hood, chemicals ang pwedeng gamitin dito. So yung movement ng air is mula sa user, hihigupin siya, lahat dito, so turbulent tong area na to, then lalabas, palabas sa exhaust yung fumes natin. So protected yung user. So sa biosafety cabinet, pinagsama niya yung concept ng fume hood tsaka laminar flow. So mula dito, pinoprotektahan yung user, i-absorb yung air dito, pupunta yung air sa baba, liligid papunta dito, papunta sa HEPA filter, tapos clean air na yung papunta sa pathogen natin. Then, yung remaining air na pwedeng ma-exhaust, HEPA filter din. So protected yung user dahil sa inflow air, protected yung sample natin dahil sa uniform laminar downflow air na HEPA filtered, and protected yung environment kasi dumadaan yung exhaust natin sa HEPA filter. So next is yung mga practices. So yung WHO naglagay through BMBL 5th edition, naglagay na sila ng mga best practices, standard and special microbiological practices for handling biosafety level 2 containment. Then yung WHO naglabas siya ng interim guidelines on how to handle BSL-2 samples using molecular analysis of extracted nucleic acid preparation, which is yun yung method na ginagamit ng RITM ngayon. And then kasama din sa admin controls, ito, pagka sinabing admin controls, so ito yung pinaka cheapest among the mitigation controls. Kasi ang kailangan lang is policies, procedures, and guidelines. So policies is controlling the behavior and actions of the staff. Then you have the practices and procedures. So ito kinukuha from the best practices across the laboratories performing or handling pathogens. So usually kasama dito yung do not eat or drink in the laboratories, avoid mouth pipetting, wear the proper PPE, and so on and so forth. Then lastly, you have your personal protective equipment. So depending on the route of transmission, you have your protective equipment to protect the route of transmission. So goggles for the eyes, respiratory mask for respiratory route. Route of inhalation is usually through the nose and the mouth. Then you have your gowns and you have your gloves. Additional is yung head cover, yung foot cover. Kung heavily yung splash, pwedeng additional na apron. Tapos kung hindi available yung gown, pwede rin yung coveralls. So yan yung ating mga personal protective equipment. So ang goal ng PPE is to provide a barrier between the pathogen and the staff. So banggitin natin especially yung respirator kasi nag-umpisa to nung ni-recommend nung nag-erupt yung Taal volcano. So sabi nila dahil microscopic yung dust na ini-emit ng Taal volcano, hindi bagay yung surgical mask. Dapat N95 mask. So ano ba yung difference ng N95 mask versus sa surgical mask? So ang N95 mask, considered siya as respirator. Ang surgical mask, hindi siya considered as respirator. Pagka sinabi naming respirator, ang PPE dapat mag-fit or mag-seal sa face ng end user. Kung hindi niya kaya mag-fit or mag-seal sa mukha ng end user, hindi siya pwedeng tawaging respirator. Tapos sa respirator, so makikita niyo may letter tsaka may number yung N95. Yung ibig sabihin ng letter, so yan yung classification ng National Institute of Occupational Safety and Health or yung NIOS. Sila yung nag-accredit sa mga N95 mask. Kung hindi NIOS accredited, hindi ko alam kung kita dito sa picture. Ayun. Ayun yung NIOS. Oh. So kung walang marking ng NIOS, hindi siya respirator. Yung surgical mask, approved siya ng FDA. So yung difference. Yung NIOS, binabalidate yung N95 mask as respirators. So yung N, ang ibig sabihin niyan, not for oil aerosols. Kung R, somewhat resistant to oil. Kung P, strongly resistant to oil. Ang numerical value, kung 95, yan yung filtration efficiency. Kung 95, 95% yung minimum filtration efficiency niya. Kung N99, 99% yung minimum filtration efficiency niya. Kung N100, 100, hindi 100% yung filtration efficiency, but around 99.97% yung filtration efficiency. Then one more thing about the N95 mask, hindi mo siya pwedeng gamitin initially kung hindi ka fit tested sa mask. So sa fit tested, kung fit, kailangan very fit yung tight fitting yung respirator, dapat kang mag-fit testing. So ang fit testing dito sa picture, ang pinapakita is yung qualitative fit testing. Meron ding quantitative, pero mas mahal yung machine nun. So mas murang i-implement tong qualitative fit testing. So ang gagawin dito is may papaamoy sa yung chemical. Kung naamoy mo siya using yung mask, failed ka dun sa fit testing. Ibig sabihin, hindi nakapag-form ng appropriate seal yung mask. Kaya mo naamoy yung chemical. So dapat kang magpalit ng ibang type ng respirator na mag-fit sa face. Tapos ito yung example ng isang loose-fitting respirator. Ang tawag sa kanya is powered air purifying respirator or PAPR for short. So ito yung mga types ng respirator na hindi kailangan i-fit test. Then we go to the hierarchy of controls. So from the controls mentioned above, so makikita natin yung hierarchy. Ang most effective is yung number 1, elimination substitution. Next is engineering control, administrative control, practices and procedures. Note, ang personal protective equipment is yung pinaka least effective. So, ang gagawin mo sa mitigation control, titingnan mo muna yung number 1. Kung hindi mo siya pwedeng gawin, you go to number 2. Kung hindi mo siya pwedeng gawin or hindi pa acceptable yung risk, pwedeng dagdagan mo siya na number 3. Kung hindi pa rin kaya, dagdagan mo ng number 4. And then, your last line of defense is yung PPE. Pero dapat, yun yung dapat maging matandaan natin. Before tayo magpunta sa PPE, kasi usually yan yung nadidinig natin sa media ngayon, kulang sila sa PPE. Hindi na natitingnan yung ibang mitigation controls na available na pwede nating i-implement na mas effective sa PPE. And then the last part of the AMP model is the performance. So this is the implementation of the entire biorisk management system, including evaluation and ensuring the effectivity of the mitigation control. This would ensure that the system is working as designed through the risk assessment. And another aspect of the performance is the process of continual improvement. So yung continual improvement, ito yung hiniram natin sa quality management. So this is the entire process of the risk management for biosafety. So you have to identify the hazard, assess the hazard for characteristics like likelihood and consequence. Then you do your mitigation control when the risk is not acceptable. Implement the controls and evaluate if the controls are effective. So that is the last of my slide. This training is brought to you by the National Training Center for Biosafety and Biosecurity. The NTCBB provides free biosafety training online. So nasa second batch na kami ng training ngayon. Pinaprioritize lang namin sa second batch yung mga lab personnel na mag-test for COVID. Pero kung gusto nyo mag-participate, mag-inquire lang kayo sa Facebook or sa website ng NTCBB. Ma'am Kim? Miss Kim?
Yeah.
No,
Yeah,
thank you
GR,
very
go
much.
ahead.
Thank you very much po. So, maraming salamat po regarding yung lecture po natin regarding my risk management. And now, we'll go to uh, yung next po part man po ng ating lecture, which is about naman sa framework po regarding development of Philippine biosafety and security. So, Dr.
Yeah.
Sige
Yep.
po. Okay po, so magandang hapon po sa ating lahat. Ako po si Jaifred Lopez. You can call me Jim. And I'm presenting this part of the lecture on behalf of the UP National Institute of Health Policy and Development Studies, where I worked with together with Ms. Kim Sales and Ms. Ida Gomez under the supervision of Dr. Hilton Lam. But now I'm also connected with the UP College of Public Health, Department of Nutrition. And right now, we are actually already aware na ang biosafety po napakadami po mga considerations. Nakita po natin na for us to really get to assess, mitigate, and perform properly, may mga kailangan po tayong dapat ayusin with regard po to our capacity to build our laboratories, ganun din po sa kung paano natin po na-maintain yung standards po natin. And of course, making sure that our laboratories are properly equipped. And of course, having that kind of laboratory or those facilities or being able to actually mobilize resources is really not just an effort of the health office. So, and not just the concern of hospitals, pero talagang kailangan po nating maipakita sa ating mga nasa taas, yung mga policymakers po natin, that these are important. And this is actually what we wanted to demonstrate with research, with this research that we did in 2018. And we just hope na sa pamamahagi po namin nitong research po na ito, more or less makita po natin kung paano po natin siya magandang ipakita po sa ating policymakers na hindi lang po talaga siya dapat sa hospital lang, kundi napag-uusapan din po siya even with the police, with the armed forces, with social security, with social welfare, with agriculture. Ayun po. So pupunta na po tayo sa next slide. Ayun po. So itong pag-aaral po na ito ay may kinalaman po sa kung paano natin pinag-uusapan ang biosafety and biosecurity. So napag-usapan na po natin ang biosafety kanina. At the same time, gusto rin nating ipakita ko anong kahalagahan ng biosecurity, na ito ay may kinalaman sa kung paano po natin pinapanatiling ligtas po ang ating mga nagsasagawa ng mga tests sa laboratorio. At the same time po, sinisiguro po nating ligtas yung mga taong nakakasalamuha ng mga nagtatrabaho sa laboratorio, as well as yung kapaligiran po ng laboratorio. So that would entail proper waste disposal, as well as proper stockpiling, proper containment. And of course, tinitingnan din po natin kung anong epekto po nito sa kapaligiran. Kasama po dito ang mga hayop at yung mga nasa paligid po mismo. So, batid po natin halimbawa na ang SARS-CoV-2 ay nagsimulang kumalat po nung siya po ay talagang nagkaroon ng pagkakataong mag-cross from a certain animal host papunta sa tao. So kumbaga ang biosecurity and biosafety ay meron din pong ganong klaseng aspeto na we would like to protect our human population from viruses that may predominate or that may proliferate in the animal populations. So hindi lang po talaga sa COVID-19 ito nakita, kundi pati po sa mga incidents na kung saan meron pong halimbawa bird flu. So meron po tayong mga migratory birds na possibly na nadadala po nila yung mga ganitong infection. So may mga ganon din po tayong considerations na eventually it will also be important sa mga probinsya po natin na kung saan dinadapuan po nitong mga migratory birds. Meron po tayong malaking livestock industry. Meron po tayong mga ganitong considerations. So ito po ay isang pagsasanib ng tatlong disiplina. So that will be biodiversity. So ito po yung may kinalaman po sa pagkakaugnay-ugnay po ng mga nasa kapaligiran po natin. Ang tao, ang mga hayop at ang kapaligiran. Kasama din po ditong agricultural security. So kasama din po dyan yung halimbawa po sa larangan naman po ng agrikultura, marami po tayong mga halimbawa po, mga pananim po na dinedevelop genetically. So meron po tayong mga tinatawag na genetically modified organisms. So kasama din po siya sa field po na ito ng biosecurity. And of course, number 3, ito po yung medyo malaki ang kinalaman po sa sitwasyon ngayon, and that will be our public health. So nakikita po natin na itong mga aspeto pong ito ay malaki po ang kanilang kinalaman po sa kalusugan ng tao, hayop at kapaligiran. So nakita din po natin na yung mga ganitong outbreaks po, malaki naging epekto po niya kasi it signaled the need for government to prioritize public health and safety, and therefore nakita po natin na ang sakit po na ito, kagaya ng SARS-CoV-2 na bakalat ngayon as COVID-19, na wala siyang pinipiling lugar. Kahit po isa po siyang bansang mayaman o bansang middle income kagaya natin o bansang mahirap, pare-pareho po tayong pwedeng tablan ng mga ganitong sakit at kaya kailangan po nating magtulungan. Sige po. Sa susunod po, next slide please. So kasama din po dito yung kahalagahan na ang mga facilities po natin ay well secured so that we don't allow any potential infections to affect either humans or animals or the same or the both. At the same time also, nire-recognize din po natin na meron pong kakayahan ang mga laboratorio, especially for various motives, na makadevelop ng mga tinatawag na biological materials of concern that eventually that can be released in one way or the other or in one purpose or the other to be able to intentionally harm a population. So ito po yung tinatawag nating dual use of science na kung saan, kung titingnan po natin yung mismong research or yung mismong gawain po ng mga laboratorio, importante siya. Pero kung may gustong halimbawa po, may intent ang isang tao within the laboratory to either make a political stand or something or for some other reason, inisip niyang ikalat yung infection or yung bacteria. So may mga ganun po, may mga ganun na po tayong nakitang kaso before, mostly in the West, pero there is possibility to have that kind of scenario anywhere in the world. So it's a research with legitimate scientific purpose, pero it can be potentially misused to pose a biological threat to public health or to national security. Yan po. And therefore, parang gusto po nating protektahan po ang ating bansa, ang ating pong mga tao laban po sa mga ganitong klaseng pagkakataon. Sige po. Next slide please. So ano pong sinasabi natin? So ang importante po para maiwasan po natin yung mga ganong pangyayari ay magkaroon po tayo ng sapat na protection, sapat po na pamamaraan po for securing our laboratories. So, kaya po importante, halimbawa, na ang mga laboratory po natin may mga PPE, kagaya po ng nabanggit, meron po tayong eye, airway, and hand protection as well as a gown. Meron po tayong mga minamandate din po ng mga biosafety levels ng ating mga laboratory. So, so far po, ang guidelines po na ipinakita kanina ay ang mga laboratories na dapat ang mga laboratories po na eligible to be assessed for potential accreditation as a testing facility for COVID-19, dapat po sila ay at least biosafety level 2. And po, so of course, there will be other considerations as the accreditation process is underway. Pero ano pong sinasabi natin? So, in general, kung suma total sa buong Pilipinas, kung titingnan po natin yung kakayanan ng ating facilities, ng ating laboratories to fulfill these standards, generally, medyo hirap tayo. We fail to meet international standards. It's not just in the Philippines, but also in the Asia-Pacific region, where anywhere these pathogens can arise because of our interaction with the environment. So in 2007, sinasabi halimbawa na sa isang survey on kung paano tayo mag-practice ng biosafety, medyo meron po tayong mga kakulangan na 80% ng scientists natin ay may PPE. So ano nangyari doon sa 20%? Ibig sabihin, hindi silang lahat ay nag-practice ng proper PPE. Isa pa po, sa mga facilities po natin, as much as possible, if you're handling pathogenic bacteria or pathogenic organisms, at least the facility should have an autoclave, especially if you're dealing with those organisms. At ang sabi po dito, 50% of facilities that had been handling these kinds of organisms, 50% lang ang may autoclave. 50% lang yung may restriction ng laboratory access na kahit sino pwedeng pumasok, lumabas, ganyan. And 33% lack training on BSS protocols. BSS is Biosafety and Biosecurity. So therefore, parang ang kagustuhan po namin sana, this is a shared desire of PSPHP as well as the NTCBB and IHUP, is to really capacitate as many laboratories as possible so that we can enlarge or increase our capacity to test. Ayan po. So therefore, para po maging posible po yun, it's a multi-sectoral effort. Pero right now, gusto din po namin ipakita sa ngayon yung kung ano po yung mga considerations para po maisagawa po natin na implement po natin siya sa level ng LGUs. Sige po. So next po, please.
Hi, it's me.
Yes, okay.
Hi, I'm Kim. So I'll discuss the policy analysis that UPNIH, the Institute for Health Policy and Development Studies, conducted. So we conducted a rapid policy review of all the biosafety and biosecurity policies in the Philippines. And these were the websites that we searched. So we looked for policies from the Department of Agriculture, DOH, DOST, DNR, RITM, and DE. We ended up finding 41 documents. And to analyze them, si Heckert and Friends in 2011 provided 9 categories for developing capacity and biosafety and biosecurity and LMIC. And I'll go through each of them in the results section. Before that, I want to present dun sa 41 documents na retrieve namin, ano yung subject nila, ano yung scope, or ano yung product na kino-cover. So it's a long list, 27 entities were there. But what we just want, the key takeaway from this list is that, as Doc Jim explained sa intro, hindi lang siya health, it's all-encompassing of security, of animals, of the environment, facilities, and even weapons. Okay, so first, one of the first categories is we have to ask ourselves, yung sa entities na yun na 27, nire-regulate ba sila with some kind of framework, standard, or practices that was developed ng ahensya ng gobyerno or even a committee that oversees? That's only true for 17 out of the 27. And for those 17, iba-iba pa yung level of detail. So minsan sinasabi lang na itong bureau na to ang assigned gumawa ng guideline. Pero after nun, parang wala na. Meron na mga ibang very specific na on its own. So, and next, what we want to say here really is that guideline development is one thing, but implementation of the guideline is very essential so that we consistently apply them to all containment levels in the country. So next is biosafety awareness. So sa policy ba, do we actively say that we should be promoting biosafety awareness advocacy? Because one of the categories also is that policymakers and even elected officials need to understand biosafety and biosecurity in order to appreciate it. And it's only true for 3 out of 27. The goal of the biosafety awareness category is that it should be available to anyone who wants to inform themselves about biosafety and biosecurity. And this is key to disseminating its principles and practices to the users, whether that's laboratorians or elected officials in government. Next, what about sa infrastructure? So pag nagtatayo ba tayo ng health facility, kino-consider ba natin yung risk ng organisms that we handle inside the facility? Even if maliit lang siya na lab, na standalone, up to level 4 na laboratory. That's only true for 17. Minsan vague yun. For example, there are guidelines that just say facility should be adequate, clean, and sanitary. But they don't define ano ba yung ibig sabihin ng adequate, ano ang clean, ano yung sanitary, or how do you disinfect so you become a sanitized facility. This is also true for how we license, accredit, and monitor and evaluate our facilities. So as of now, wala masyadong consideration for biosafety, biosecurity, or biorisk assessment. I can talk more about this later, but basically we apply a current, an input-based method to how we accredit or license our facilities. And that's not necessarily translatable to saying na if I have all of these equipment, that means my lab is relatively safe and free from risk or low risk. In fact, we should also be considering reliable electrical powers, quality roadways, and transportation networks when we talk about biosafety and biosecurity infrastructure. Next, what about our equipment? So for 17 out of 27, they do provide equipment guidelines. It includes what the minimum equipments are for a facility to be given a license to operate, and it also includes preventive maintenance. For our policies, sometimes it indicates kung sino lang yung purchaser ng for the sub-national laboratories. So what does that mean? So the laboratory cannot decide for itself. It has to be the purchaser that has the power to purchase or not purchase probably what the lab needs. But literature kasi states that this needs to be, the maintenance repair certification needs to be available at all times. And later I'll talk more about, I guess, the implications for clinical laboratories. Do our policies mandate the existence of an institutional biosafety committee, or at least man lang a biosafety director within a facility? That's kind of true for 20 out of 27, but we don't go as far as designating a biosafety officer or director. Usually, it's just a committee that oversees its implementation. But it's important to have this because it is the committee or the person that gives authority to develop and implement the biosafety program. And lastly, do we consider in the recruitment process of our laboratorians or any hospital staff their BSS proficiency or training? That's only true for 8, and sometimes they do include it na parang kailangan the staff is familiar with some biosafety concepts. However, they do not explicitly mention a continuous education or training program specific to biosafety. And in addition, out of the 9 categories, we didn't find any mandates for the last 3, which is the biosafety curriculum. Second is the creation of biosafety associations. And third is the individual mentoring and organizational twinning, which are 3 other aspects that are important to capacitate the people in hospitals and other health facilities. So, which agency is ultimately accountable for implementing biosafety, biosecurity practices? For us, there is a National Committee on Biosafety, and each government agency has its own may sarili silang bakod. So for the Department of Agriculture, it's of course agriculture and food products. DNR is responsible for environment impact assessment. DOST make sure that we use the best available science when we handle non-indigenous organisms or organisms in the risk identification sheet. And of course, DOH is in charge of health impact assessment. Doc Jim, you wanted to do this slide.
Okay, hello. So sa pagkakataon na to, nakikita natin na ito lahat yung dapat na medyo conscious ang mga laboratories natin. So na as much as possible, we would like to ensure that the guidelines are able to subsume all of these potential threats or all of these potential areas where a threat can be it can be picked up. So now, nilagyan lang namin siya ng mga ganitong categories just to see how they relate with each other. Kung ano yung parang pagkakaugnay-ugnay nila. And nakikita natin na meron pong gap between being able to bridge security risks and all the other aspects of laboratory safety. So, bakit siya importante? Kasi right now, nakikita natin halimbawa na ang ating pong mga nasa armed forces, for example, or yung mga nasa uniformed forces natin, yung mga police, na right now ay talagang malaki ang kanilang role for containment because of our checkpoints, because of the need for them to enforce the lockdown. Right now, there is hesitance from their part to participate in the current containment strategies. So kumbaga parang and we think that this is so because from the very beginning, wala talagang na-illustrate na connection between bridging the security sector with the laboratory sector. So kaya ang parang takeaway point from our research at least from this slide is maganda sana po nasa mga LGUs at saka sa mga hospital, maganda po sana na-involve na po natin yung mga nasa uniformed forces. So that would include our police, our Bureau of Fire Protection, as well as our military for those who have military posts nearby. So para po at least aware din po sila kung paano po ano po yung dapat pong PPE nila whenever they man the checkpoints. At the same time also, eventually po, kung natapos na po itong sitwasyon natin ngayon, at of course, we will have to maintain pa rin that kind of guard, especially since ang infection di naman natatapos yan. So there will always be opportunities for new infections to emerge. So therefore, there also needs to be a team up between all of these sectors. Animal science, so yung ating po mga nangangalaga sa mga hayop. So for the LGUs, this will be the municipal agriculturists. Kasama din po dyan yung entomology and plant science. Agriculturists din ang nag-aasikaso niyan sa LGU. Biotechnology, so that's why we hope that LGUs as much as possible, kahit man lang may isa silang medical technologist. Kasi like, for example, in my time, nung nasa LGU pa ako, wala talagang mga medtech na nangangasiwan, nag-aasikaso ng laboratories. So of course, kasama din dyan yung you have to have your own laboratory in the first place for those who are in the RHUs, and for those who are in the hospitals. Nabanggit kanina ni Ms. Kim yung importansya na you have to have a biosafety committee in your respective hospitals, or at least a hospital infection control unit that would allow you to address any infections that might be a cause of sickness within the hospital workforce. Ayan po. So I hope na this slide will somehow allow us to illustrate the importance of all these sectors, and we have to work together. Okay, sige. Kim?
Okay. So I was asked to give implications of the current situation and the results of the policy review to laboratorians in the clinical setting. I can only talk about the clinical setting kasi doon lang ako may experience. So for me, clinical laboratories are unique environments. They're different from academic or research laboratories. Why? Kasi when you get a specimen in the clinical lab, the risks of that specimen to you is always initially unknown. Unlike in a research lab na alam mo kung ano yung research mo. So people know if they're researching Ebola, they handle Ebola specimens. So they apply precaution applicable to that kind of specimen. Pero sa clinical laboratory kasi, even beyond this pandemic, it will continue to function that way. So it will encounter routine like E. coli, or emerging like COVID, and re-emerging like Ebola is a good example, or measles. It will continue to encounter these kinds of organisms in an initially unknown status, and we wouldn't know what it is until we conduct testing. So what we are taught in school is you practice universal safety precaution. So you err on the side of caution, you assume that all samples are infectious. And I think there's an honest there's an honest effort for medical technologists in the country to try and practice universal safety precautions, but this is hindered by two things, I think. First, this is not just true for us, but I think in global laboratory practice, there is a focus more on quality, accuracy, and efficiency. So, kailangan mabilis ka maglabas ng result. Sensitivity, specificity ang usapan lagi when it comes to tests. But safety is almost seen as an inconvenience if yun yung culture in the lab. So another factor is, of course, the limited resources, which we now see with the lack of PPE. Or, it can even, I mean, the most common and basic thing you can encounter is we don't even have some facilities, I would say most facilities, cannot even segregate their waste properly kasi wala yung proper color ng garbage bag. So, ganun siya ka hindi importante na parang if you ask kung medtech ka sa isang lab and you request na can we buy yellow plastic bag so we can dispose and segregate our trash properly, parang laking inconvenience pa siya sa laboratory management. So for me, personally, what do I recommend? And I have professional opinion also. Let's follow the AMP model, which was discussed earlier. In the lab, there will almost never be a scenario na walang risk. You can only reduce it, but you cannot. The only way na walang risk sa'yo is if you don't work in the lab. So I've put this picture here of swab collection because that's how we collect specimens for COVID-19. Just imagine if you're doing this swab na walang gloves yung medtech, acceptable ba yun sa'yo? If hindi, how do you mitigate that risk? So the most obvious thing to lower it is wag kang mag-collect ng sample, but of course that's not possible. So when you do the AMP model, you should identify the risks and ano yung level na acceptable sa'yo. So okay lang ba sa'yo na wala kang mask habang nagpo-process ka ng sample? Okay lang ba sa'yo na yung gloves mo in a day, isang gloves lang? Like you reuse the same gloves throughout the day. And in the case of non-traditional laboratories, which I'm not sure if we're doing, so non-traditional labs are kind of temporary laboratories that are built in the case of emergency. They're kind of built in the field. Tapos they're not meant to be there permanently. They're just there until a crisis is over. It's the same advice. So conduct risk assessment on the entire spectrum of your operations. So hindi ko alam if may lab na ba tayo na dedicated lang sa COVID. I think yung sa Marikina na issue today, the one that will operate without a license is dedicated only to COVID. So kung ganon, what are the risks? Or if may bagong lab na mag-a-add pa ng ibang procedures on top of COVID, then ano yung other risks that you need to take into account? And you should implement mitigation strategies. For me, these 5 things should be considered. So right now, we don't have a lot of testing laboratories, right? So in the Philippines in particular, we have a big send-out culture sa lab. So what that means is you collect the sample in one laboratory and then you send it out to the laboratory that has a capacity to do the testing. So if we do reach that point na parang pwedeng mag-collect ng sample in a non-COVID accredited facility, tapos isi-send na lang like sa RITM. What is our local capacity to transport the sample? Ano yung risk na may in-transit loss or matatapon yung specimen? Second, is for sample security. So, saan natin sinustore yung sample? It's also related to the transport, loss, or release. And are our facilities designed so that only authorized people can enter and exit the lab? As far as I know, that's not true for like the common labs. Hindi naman siya parang may fingerprint scanner or entry and exit. So commonly, it's just a door and anyone can walk in and out. Next is PPE. Is the appropriate PPE available? And then, of course, we have to consider decontamination. What's the inactivation or decontamination na available sa'yo locally, or do you have to import it? And if you have to import it, tas may available na local, what's the quality of the local contaminant compared to the one that you have to import? And of course, waste disposal. Like, what is the local capacity to dispose of liquid, solid waste repurposing, and disposing of biological waste. Um, so that's it for me. So I'm gonna throw it back to Doc Jim for the LGU implications.
Okay, thanks, Kim.
Yeah.
Magandang makita din natin to from a bigger perspective kasi nakita natin, for example, if you could look at the previous slide, can we go back? Kim, dun sa
Sure.
previous slide. Ayan. Actually, magandang makita natin siya in the context of these things. Kasi like, for example, sample transport, does that necessarily restrict only to the health sector? Definitely hindi. If you're dealing with an LGU hospital or an LGU RHU, parang nakikita natin na anong capacity ng ating mga LGU na mag-securely transport ng mga specimen, and eventually, in the current situation, how can we actually transport patients who are for testing? So, that is important as well. Next is yung parang how do we ensure na meron tayong enough resources and facilities for waste disposal and then decontamination. And right now, nakita natin even personal protection and security are at risk kasi nga kulang tayo sa PPEs at walang pondo for everything na ito. So with that, we would like to therefore propose all these strategies that would somehow allow our LGUs and our first line facilities to have a better access to all of the facility or all of the resources that would allow them to procure all of the necessary equipment and consumables. So first is, sana po, nare-recognize po ng ating mga nasa LGU and of course for those in the hospitals, for the board of directors perhaps, na meron po tayo talaga dapat role in terms of biosafety, biosecurity, and biorisk management. So malaking tulong po, especially for the laboratorians to attend the biosafety course of NTCBB, as well as for those who are in the decision-making duties ng mga LGU and hospitals to be conscious that biosafety, it's not just the laboratorian's business, it's actually everyone's business. So that's why it's important na may policy po tayo regarding that. Next po is in terms of inclusion of funding and related activities in the budget. So this is actually the study that we did was for a national setting. But to put it at the LGU and hospital level, importante po na talagang meron pong nakalagay po dyang mga items on how we could actually ensure that there are resources that are dedicated to biosafety and biosecurity. Number 3 po is better regulation of facilities and activities which may pose risk. So, ang pinaka-importante pong consideration for this, the risky activities is transport. So, kasi po ito po yung opportunity for infection and for pathogenic substances to enter a certain jurisdiction and potentially infect a lot of people and also affect the environment. So from an LGU perspective, nakita na po natin yan. We have different kinds of checkpoints and lockdowns already in place, and therefore, if we are to eventually transition into a situation na okay na, of course, we'll never know when will be the next pandemic happening. So therefore, we have to be ready pa din. And that's what we're trying to build here. And number 4 is engagement of stakeholders. Kasi this is not necessarily just the work of the LGU and the hospital. You also have to deal with, for example, if you're dealing with private laboratories, for those in the LGUs, and eventually, if you will also engage them in the testing, especially since may mga RHUs tayo na, of course, they don't have a laboratory. It would be nice to engage a private laboratory, mag-MOA kayo, to come up with an arrangement na makapag-send kayo ng specimen sa kanila and all those things. But at the same time also, with how the previous, the things that were enumerated in the previous slide can actually be implemented, na of course, hindi naman lahat ng RHUs and LGUs natin ay well-equipped, that's where stakeholders can come in and assist. Ayan. And another thing, taking off from the importance of stakeholders, we would like to demonstrate that with what we call a tabletop exercise. Ayan. So bakit siya importante? Kasi this is actually a way for us to forecast or to look at how will our organization handle this kind of situation. So this is a practical, efficient, and cost-effective way for organizations to prepare for emergency response and recovery. And ideally, this is done before an event happens. It is not too late, but at the same time, magandang nagawa na natin siya before. Pero since we are in a setting where relatively, a lot of the LGUs that are outside Manila are medyo okay pa naman. So you can actually still do tabletop exercise. So the purpose is to ensure that the plan for whatever it is that you are planning for with regard to COVID-19, so maybe that will be building up your laboratory or addressing the disastrous effect of the COVID-19 in your municipality. So to ensure that the plan would stand up to a real event and that there are no important gaps in policies and procedures. Number two is to train the key persons that are involved. So we will have to check, for example, are our laboratories ready? Are the health officers ready? Are our uniform personnel ready? So we have to assess that. So i-share ko lang to na there was this one time 2 years ago when we were doing this na nung nag-tabletop exercise kami and there was a pandemic situation that was forecast that was simulated before. Nakita namin na may butas na kaagad kasi sa LGUs hindi alam kung sino nga ba mag-handle. Si fire ba? Si police? Si ganyan. So therefore, magandang nakikita na yun beforehand. And number three is to strengthen the interdepartmental, interagency, and intersectoral links between the various organizations that may be involved. So these definitions are actually from the WHO. There is actually a manual for tabletop exercises. But it is actually very important to look at how the tabletop exercise can pinpoint ano nga ba ang butas dun sa inyong plano, ano yung mga resources na kailangan nyo procure, ano yung skills na dapat built up sa mga tao doon sa facility at sa LGU. Okay. So right now we will be proceeding with a video just so we can demonstrate the multi-sectorality of the biosafety and biosecurity.
These epidemic events are getting more and more disruptive to health and to economy. And the reason we called it Event 201 is we knew eventually one of those days, one of those events would be the big one. And that big one would really challenge our capacity to respond. And to respond to the big one, we do need to have all hands on deck. Participants are confronted by a hypothetical scenario that presents to them the challenges of a response. So we will say, here's a hypothetical disease outbreak. This is the way it might be evolving. And these are some of the challenges that you'll see that you'll have to address to address the disruptions that you're seeing to your healthcare system or to your organization. All stakeholders realize pretty quickly just how underprepared we are and just how much is possible when we work together. And that the individual actions of any government or company won't add up to a proper global response. I think if we're honest with ourselves, collectively, the international community has never done enough to respond to global health security challenges. That we knew before COVID that the world was underprepared for biological risk. When we walked into the room in New York, if you would have asked, do you think the world is prepared for a pandemic? I think everyone around that table would have said no. But it's when they walked out, I think it's when we really knew that if we are going to get ready, we need to have operationalized and integrated public-private cooperation that we haven't seen before.
Okay, so I hope nakita natin with the video that we actually have an important role to play, not just if you are in the health sector, but if you are dealing with even with business. Nakita natin na, for example, importante na malaman natin ano nga bang options ng mga taong kumita ngayon. Kasi nga wala tayong opportunity to go outside and work. So of course, this situation actually gives us an opportunity to think about how such a disease will impact our lives. And this is why we are really emphasizing the importance of biosafety and biosecurity, because it's not just for laboratories, but it's for everyone. Okay po? So with that, we would like to give the floor to our host.
Thank you very much po sa ating napaka na lecture. So ngayon po, we'll now proceed to ating question and answer. And kung meron po tayong tanong, pwede po tayong i-chat po dito sa ating, i-type na lang po through chat para hindi po magulo and para may isa-isa po natin. Bali, so far, may nagtanong, siguro po ito ay nung kanina, yung nagtotalk po si Sir Edsel regarding dun sa mga different types of laboratory. Kasi ang tanong ko din, anteroom, tama po ba? May anteroom for yung third level, tama? Second and third level po ng laboratory sa biosafety. Tama po, Sir Edsel?
Yes, sa biosafety level 3 at sa biosafety level 4, may requirement na yung entrance maglagay na ng anteroom. So sa biosafety level 3, one anteroom is enough. But for biosafety level 4, 2 or more anterooms may be required depending on the pathogen being handled. Tapos i-correct ko na rin lang din. So kanina sinabi na yung biosafety level requirement for COVID-19 testing is biosafety level 2. So etong biosafety level 2 na guideline is guideline galing sa WHO at saka CDC na yung mga samples sa clinical laboratory is kailangan i-process sa biosafety level 2. Kung gagawa ka ng viral culture or large quantity of SARS-CoV-2 virus yung i-manipulate mo, kailangan mo na ng biosafety level 3. Dito sa Philippines, ang RITM, ang ginagamit nila method for SARS-CoV testing is yung qPCR or yung RT-PCR. So sa requirement nila, hindi lang biosafety level 2. So ang requirement nila, merong enhancement or may plus dun sa biosafety level 2 kasi may possible na may aerosol yung virus. So pagka na aerosol yung virus, kailangan mo na i-control yung room. Kailangan may negative pressure na siya. Tapos kailangan meron ka ng biosafety cabinet. Ang minimal requirement is biosafety cabinet class 2 type A2. Yun yung kanilang minimal requirement. So I hope that clarifies the question.
Okay. Thank you po very much. Meron pa po tayong isang question po dito. Ang tanong is, since spraying or misting is discouraged, what are the recommended procedures in doing decontamination? Sino po sa ating
pwedeng ako
speakers?
yung sumagot?
Yes po.
Okay.
So for decontamination procedures, so sa US, yung kanilang Environmental Protection Agency, so nagbigay na sila ng list N. So pwede kayong pumunta sa website ng EPA, search niyo yung list N, tapos nandun lahat ng disinfectants na effective against SARS-CoV-2 virus. So usually, ang mga included doon is yung mga typical disinfectants natin. Luckily, yung virus, madali lang siyang patayin. So 70% ethanol included, hypochlorite solutions included. So sa atin, yan yung mga kahit na household bleach. So 1:10, saka 1:100 dilution yung kailangan gawin. Tapos, mga per acetic acid or hydrogen peroxide included din. Ang alam ko sa DOH, kaya nila pinagbawal yung misting or disinfectant kasi hindi sila sigurado kung anong type ng disinfectant yung ginagamit. So remember, ang disinfectant, so under decontamination, yung disinfectant, ginagamit siya for inanimate objects. Pagka antiseptics, yun yung mga yun yung mga decontaminants na pwedeng gamitin sa humans. So kung disinfectant, pwede mo siguro siyang gamitin once sa humans, pero kung continued na ginagamit mo, magiging harmful na siya. So yun siguro yung point ng DOH. Disinfectants yung ginagamit instead of antiseptic. So I hope that clarifies the question.
Okay, thank you po. So kung meron po tayong sagot or gusto po nating magdagdag sa ating mga speakers, pwede lang po tayo mag-butt-in. So next question po is regarding naman po yung sa use of Gene Expert. So kung makakapag-run po ng sa Gene Expert, ano pong kailangan na precautions and BSC na kailangan?
Mukhang ako ulit.
Yeah.
Opa, yes.
Okay.
Pag laboratory questions, yes po.
So yung Gene Expert, for the information of all, so ang Gene Expert, ginagamit siya usually for TB diagnosis. So ang kagandahan sa Gene Expert, product kasi siya ng CEPID, tapos in-adapt siya ng DOH. So ano siya, parang qPCR din siya, pero considered siya as point of care testing. So ang kagandahan is in-adapt siya ng DOH for TB diagnosis. Meron na tayong 50 labs na may Gene Expert across sa whole Philippines. So ang problema lang, wala tayo nung cartridge para sa SARS-CoV. So siyempre, bagong manufacturer pa lang ito ng manufacturer, yung CEPID yung manufacturer, hindi natin alam kung magman-manufacture sila ng enough units kasi US-based itong CEPID eh. Sa US, ang daming infected, di ba? So, kailangan din nila ng mass testing. So, hindi lang natin sigurado kung makakarating yung Gene Expert cartridge dito sa Philippines. Pero kung nakarating, since considered siya as point of care testing, mas mababa yung biosafety requirements niya. Kasi ang point of care testing, kung nasan yung pasyente, nandun din sa area na yun gagawin yung test. Tapos usually kung point of care testing, mga 1 to 2 hours lang may result ka na. So ganun siyang kabilis. Pero sa TB kasi sputum yung ginagamit. So dito sa SARS-CoV, ang ginagamit is yung nasopharyngeal swab o yung oropharyngeal swab. So yung collection pala, meron ka ng possibility ng formation ng aerosols. So collection-wise, tapos ayun, kailangan makita muna natin yung specific activity and processes ng Gene Expert. Meron bang centrifugation involved? Meron bang vortexing? May pipetting? So yung mga activities na binanggit ko, possible siyang mag-generate ng aerosols. So kung nag-generate siya ng aerosols, so katulad sa diniscuss natin, i-consider natin yung route of transmission. So kung by inhalation siya, yung mga gagamitin nating controls is for inhalations. Like yun nga, using biosafety cabinet, and for the PPE, using a 95 respiratory mask. So I hope that answers the question.
Yung next question naman po natin, parang niisa po tayo yung mga test. So yung next question naman po, paano naman raw po yung rapid diagnostic antibody test? So kung anong biosafety level yung kailangan, and kung pwede ba siyang i-run without biosafety cabinet?
So again, kailangan muna nating i-risk assessment ulit. So isang requirement para ulitin or gawin uli yung risk assessment is nagkaroon ng change of procedure. So dito, hindi lang testing method yung nag-change. Possible, nag-change din yung sample. So usually kung ang minimin niya sa rapid testing is yung laminar flow immunoassays, usually ang sample is blood or other body fluids. Pero usually blood. So kung blood, less, hindi siya gano'n nag-generate ng aerosols. Tapos kung diretsing ilalagay yung blood dun sa test strip, tapos hindi na isa-sentry, mas safe siya or mas bababa yung mga containment levels na kailangan or practices na ipang-mitigate dun sa hazard. Pero since blood pa rin siya, tulad ng nasabi sa lecture kanina ni Ma'am Kim, lahat ng bloods and body fluids sa laboratory, kino-consider namin siya as potentially infectious. So, i-govern pa rin siya ng safety precautions o yung kung matanda na kayo, ang tawag namin dati is universal precaution. Ngayon, ang tawag na sa kanya safety precaution.
Okay. Matanda na din pala ako kasi sabi ko universal safety precaution. If I can add then na parang emphasize na even if yung sample ni-request siya for COVID testing, it can always be negative. Like, di ba, parang may statistic na lumabas last week na 80+% of COVID tests that we have conducted have turned out to be negative. So this is why important yung universal safety precaution kasi iba yung sakit niya eh. Like, it didn't turn out to be COVID. So it could be something else. So I think yung approach na gusto kong iparating about biosafety sa lab is you never know talaga kung ano yung kinakaharap mo pag humahawak ka ng sample. Whether it's COVID or not, you never want to risk infecting yourself and subsequently infecting your family or the environment or your surroundings. So yun.
Mag-comment lang din ako dun sa 80% na
Yeah.
So, yung nature kasi nung test na ginagawa is qPCR tapos yung type of sample. So, ang unang cause nung negative is possibly yung specimen collection.
Yeah.
Hindi proper yung
not properly collected. Yeah.
So, hindi na-pick up. Second is, nakuha ba siya dun sa tamang stage na present yung virus? Kasi kung masyado pang maaga at konti pa lang yung virus, possible na mag-negative siya. Tapos remember, yung claim ng kahit na ang sabi ng DOH gold standard yung RT-PCR natin for testing, sa laboratory side, around 60% lang yata yung kaya niyang i-detect na positive. So may around 30 or 40% siyang mamimiss. So talagang pagka nag-negative siya, hindi ibig sabihin na negative yung patient. So dapat i-correlate ng physician dun sa mga clinical findings and other diagnostic tools na available like CT scan.
Yep. Agree dun sa first point. It might be the kasi public health. Sample collection na error. Kasi speaking from experience, nasopharyngeal swabs, hindi siya talaga masyadong ginagawa. And even if you were an intern sa hospital, since very sensitive kasi yung test na ginagawa na kailangan mo ng nasopharyngeal swab. So usually, it's actual licensed medtech that does it. So yung opportunity for medtechs to collect in that way, medyo limited. So they might not have practiced it as much as, for example, phlebotomy. So yeah, kasi may pre-analytic, analytic, and post-analytic stage that you can encounter an error. So of course, sample collection is the pre-analytic phase. Did you collect at the right time in the right manner? Yeah.
Thank you po. Yung next question po natin is kung meron pong science behind putting food shots in the checkpoints given the COVID-19 mode of transmission is through droplet.
I think yung, to answer it in a practical sense, kasi dahil airdrop ang transmission, you can actually end up having virus droplets in the floor. Parang
Yeah, I think so too.
I think that's one also another consideration. And of course, wherever you go, madadala mo siya. Ayan. Sige, maybe other more technical explanations. Parang gano'n lang naman siya eh.
Sa viral, ano tawag, nalimutan ko yung proper term eh. Yung survivability niya sa environment.
In the surface?
May recent study kasi na nilabas na, so for different materials, different yung survivability niya sa environment. So hindi ko alam yung saktong mga pero for plastic yata 7 days. Parang gano'n.
Matagal siya.
Yeah, matagal siya yung plastic, metal. Yeah.
So depende sa surface kung saan siya nag-drop, yung survivability niya. So kung matagal yung survivability, yun yung isang explanation bakit maano yung transmission niya. So ang isang practice sa mga animal facilities dito sa Philippines, naglalagay sila ng foot bath bago ka mag-enter sa facility nila. So kahit na yung paa, so nakita ko ini-implement na ng ibang mga LGUs yun eh. So yung concept na yun, usually baka na-adapt nila sa mga animal facilities. Tapos ayun, kaya nagkaroon sila ng disinfection tents, di ba?
Okay. Yung regarding naman po dun sa, meron ba po tayong ma-recommend na biosafety protocol or document na pwedeng gawing reference ng mga LGUs para yung gumawa sila ng protocol pag-transport ng mga samples to the testing lab?
So, sa policy review, naka-encounter kami ng guideline from our RITM, but yung RITM develops a guideline separately per organism. So I'm not sure if nakalabas na sila ng guideline for for COVID-19 virus na guideline kasi it's lahat nakasulat doon but it's a very laboratorian perspective. Pero may transport pa din doon, like kailangan cold chain, how long can it survive, transport if cold chain, if hindi cold chain, nakasulat din ata doon. Tapos parang may time limit lang na it has to be in transit. So I'm not sure if may ganun nang nalabas for COVID-19 yung RITM, but for other specimens, sila kasi yung naglalabas, at least from what I know.
So for standards and guidelines, internationally, meron tayong, for US, meron silang select agents. So yung version natin doon, biological material of concern, kaya lang, unfortunately, hindi pa siya tapos. Pero sa kanila, so kung part ka ng select agents, i-classify nila into two types, category A and category B. So yung category A, yun yung mga controlled substance. Yung category B, yun yung mga human samples for clinical laboratory testing. So for both yung category A and B, isa lang naman yung packaging. So ang sinusunod nila is yung triple packaging system ng IATA. So ang nagbabago lang, so packaging remains the same. Tapos depende sa amount ng sample or sa type ng sample na pinapadala. Tapos tingnan nyo na lang yung rules with regard to air transport, land transport, saka sea transport. Pero internationally, yan yung ginagamit. Dito sa Philippines, ang problema lang, ang mga couriers natin, hindi sila IATA certified. Pero yung mga international partners nila, yun yung IATA certified. Pero kung magpapadala kayo, i-practice nyo na yung triple packaging system. So sa system na yun, mape-prevent lahat ng spills, leakage, or environmental spills kung susundin nyo yung triple packaging system. So safe na safe yung system na yun. Ang hindi lang covered nun is yung biosecurity aspect. Kasi ang biosecurity aspect, nako-covered kung IATA certified yung isang courier. Or kung hindi na lang kayo gumamit ng courier, yung personnel ng institution yung personally magdi-deliver sa mga magsa-send out sa ibang institution.
So yung last point is the common practice. So, usually, since hindi nga, we don't have, in couriers locally do not have capacity to properly transport samples, infectious samples. Ang ginagawa usually yung laboratory aid. Sila yung dinedesignate din na transporter to another facility. So it doesn't matter kung nasa Marikina yung lab, sila ang mag-transport niyan hanggang RAPM sa Alabang. So, we don't apply as for my experience anyway, we have never applied the triple packaging rules. It's kind of shoved in this kind of ice box. Tapos parang bahala na siya. Kung may matapon doon, kasi we don't have the equipment to ensure na safe yun, na walang spillage. I mean, yun lang yung limitation that I was presented with when I was working in a clinical laboratory. To share.
One more point. Two things nga pala nalimutan ko. So, for local transport, may nilabas na bagong directive yung Bureau of Quarantine. So, kung magpapadala kayo ng biological samples, kailangan kayong kumuha ng parang permit sa Bureau of Quarantine. And then, another thing is kung may mga laboratories kayo na kilala na nagda-drug testing, may tinatawag yung drug testing ng DOH na chain of custody. So, yung chain of custody, mako-cover niya yung security aspect ng pagta-transport ng samples. Kasi from one point to one point, kailangan may documentation tsaka may verification na nakarating yung sample. So, yun yung mga magandang local practices na pwede nating tingnan.
Okay. Thank you po. So, next question po is how to strengthen yung protocols regarding sa designating ng BSS officer. Iba pa ba siya sa safety officer ng hospital, which is ang common qualification is registered nurse?
Actually, ang problema kasi sa safety officers natin, it's actually a wider competency eh. Kasi safety will also have to deal with yung occupational safety, which is of course OSHA. OSHA is definitely important. At the same time also, hindi lang naman din siya biosafety. Kumbaga parang we're also dealing with ergonomics, halimbawa, environmental and engineering controls mo. Na it's not just for hospitals but in all workplaces. So having said that, I think kailangan meron ding training yung safety officer for biosafety and biosecurity. But I think there were also policies na we have to take into account. Maybe Kim has more information on that.
I think this should be a dedicated person that's separate from the safety officer. Like one of the recommendations dun sa framework na ginamit namin na 9 categories. It's really a separate skill set. So it's not the same as a safety officer. It's a safety officer, I agree, this is more DOLE, OSHA concern. Pero a biosafety person would really be concerned about keeping the risk low, keeping infections contained. Yeah. So yeah. I don't know how to strengthen. I think the best way to do it would really be to improve our information. Like, how do we... I'm going to answer a question with a question, but making people care more about biosafety and biosecurity and making it part of the laboratory or health facility culture. So first, parang appreciation muna before we strengthen. Like, naintindihan na ba nila why we need to care about biosafety?
Can I add?
Yes po, please.
So for context, i-enumerate ko muna kung ano yung mga officers na available na under sa Philippine law. So sa DOLE, so nire-require nila yung nasabi na safety officer for every 100 personnel sa isang company. Then you have your data privacy officer from the Data Privacy Commission. Then you have your pollution control officer for environmental protection officer from EMB. Tapos you have your infection control officer galing sa Infection Control Committee. So pagka sinabi kasing biosafety officer, traditionally kasi, so sa US, ang biosafety officer na naka-assign is galing sa IBC. So ang nag-create kasi sa IBC, sumasagot sila sa US NIH na nag-handle ng mga research ng mga recombinant DNA. So kailangan talaga nila ng IBC tsaka ng biosafety officer. So yung biosafety officer, kung ano yung diniscuss natin sa biosafety kanina, yung mga containment levels, yung mga mitigation control, biosafety levels, sila yung nag-a-assume ng responsibility na yon. Ang kagandaan sa US NIH, meron silang kakayahan na i-implement to kasi ang mga research na ina-approve nila, kung walang IBC tsaka biosafety officer, hindi nila ipafund. Dito sa Philippines, yun yung challenge. So paano mo papasunurin yung mga labs or hospitals or mga research labs na gumawa ng kanya-kanyang IBC committees tsaka mag-designate ng mga biosafety officers since walang law or regulations na nagre-require sa kanila na i-implement to. So sa DOH, kung laboratory ka, doon sa bago nilang requirement, sa mga manual, naghahanap sila ng biosafety procedures. Kaya lang, procedures lang yung hinahanap nila. Walang sinabi yung DOH na magbigay ka ng biosafety officer. So yun yung magiging challenge dito sa Ang maganda siguro, since effect nitong COVID-19, so makikita siguro ng mga leading officials natin na ito yung pagkukulang. Tapos, meron kasing biosafety nabanggit kanina sa lecture kanina, yung National Commission for Biosafety of the Philippines. So sila talaga yung may under the an executive order from President
Arroyo.
Arroyo. So siya yung nag-create ng NCBP na mangangalaga sa biosafety. Kaya lang, mini nila yung biosafety as safety from genetically modified organisms. Hindi nila sinama yung safety aspect at security aspect ng mga labs at different organization or sectors dito sa Philippines. So kung sana ma-integrate yun sa function ng NCBP or mag-create yung DOH ng separate na biorisk department, mas maganda sana para mas centralize yung pag-implement ng biosafety and biosecurity dito sa Philippines sa mga clinical labs.
We tried.
Also, I also want to input sa point ni Sir Edsel. We did try. Sa point ni Sir Edsel na when you are licensed, when you are inspected para makakuha ka ng license to operate, ang isang hinahanap nila is first the standard operating procedure, which should not be the same through all laboratories because each laboratory is unique. Second, na parang So para the second is hinihingian ka na ng biosafety procedure and manual. And it goes back to what I said in the lecture na sabi ko babalikan ko. And it's the nature of how you regulate the facility. So it assumes that if you have something, you apply it properly in a process, which is not true. From my experience, may mga time na if I have friends who are working in a new lab, humihingi lang sila ng kopya sa akin nung existing manual ng lab ko and my procedures. Tapos parang they just print their own. Tapos kasi it's something that it's in an input-based regulation. If you just need to have something in order to get a license, I think that's the weakest link. So parang it assumes na you're using it properly, but actually baka hindi. So that's just what I wanted to say na I agree, this made us realize kung saan tayo medyo weak pa kasi in a regulatory perspective, we should look into evaluating also processes rather than equipments, facilities, and people.
Okay. Sige po. In the interest of times, meron lang po tayong last two question. Yung first question po natin is, since marami nang na-infect na mga health workers, kahit na full PPE po sila, recommended ba yung pag-mimis or spraying ng disinfectants prior to putting on PPEs.
Yeah.
And yung last question po natin, i-kwento na lang po na sabihin ko na lang po yung dalawa. Yung last question naman po natin is merong study kasi na pwedeng tumagal yung COVID up to 37 days and meron ding 3 to 14 days na window period na walang symptoms. So, sapat ba yung 14 days na quarantine for it? So, yun na lang.
Yeah, I'll answer the first question because it relates to yung last kong sinabi. So, despite wearing a complete PPE, you still get infected. It goes back to that, like, even if you have complete PPE, paano ba nila ginagamit yung PPE? Saan sila donning and doffing ng PPE? So, when they transfer rooms, do they also change their PPE? Or hinahawakan ba nila yung mukha nila habang naka-gloves? Kahagabi, in the news, nakita ko yung parang this person who composed this song was singing along with the health staff. Tapos naka-glove, naka-full PPE sila, pero yung so naka-glove sila, pero hawak nila yung phones nila and they were touching it. So parang, do you also disinfect your phone once you take off your PPE? Because it's easy to transmit. Then walang sense. If hinawakan mo yung phone mo, wearing your PPE, tapos paglabas mo, you have your bare hands and you didn't disinfect. So I think it's really important for us to, beyond having enough PPE, how do you use it? Do you use it properly? Do you touch your hair? Do you touch your face? I mean, I don't know. I mean, that's just my input. Beyond having adequate PPE, how we use them and using them correctly is even more important. Yeah.
Can I add something?
Yes po.
So, katulad ng na-lecture kanina, so kung mapapansin nyo, dun sa hierarchy of controls,
yeah,
ang lowest is yung PPE. So, pagka pumunta ka na sa PPE diretso, nang hindi mo tinitingnan yung ibang mitigation controls, so siya yung pinaka-least effective. Kaya siya yung tinatawag namin pinaka-least effective. Kasi nandun pa rin yung hazard. Exposed pa rin yung tapos ang protect lang sa kanya is yung thin barrier ng PPE na yon para hindi siya ma-expose. Tapos, in case ng SARS-CoV, invisible yung enemy natin. Hindi natin ma-detect kung nasan siya. So, hindi natin alam kung saang surfaces siya nandun, kung contaminated ba yung air. So, any mishap or mistake, talagang may possibility ng infection. Tapos, connected to sa answer sa number 2 question. So most ng infections daw, sabi sa isang report, nangyayari due to asymptomatic patients. So walang signs and symptoms yung patient pero na meron present yung virus sa kanila. So kung yung healthcare worker, wala siyang PPE dun sa humarap dun sa isang patient na sa tingin nila is walang signs and symptoms, possible doon nangyayari yung infection. Second comment is, so doon sa AMP natin may performance part, diba? So hindi lang naman dito sa Philippines nangyayari yan, kahit na sa ibang bansa. Ang performance is, sinecheck mo ba kung effective yung mitigation control, which is the PPE. So sa Philippines, ang nagiging practice, diba? Ito ang PPE, dumating yung supply, check ko lang physically kung okay siya, tapos susuot ko na. Pero hindi natin tinitingnan, validated ba yung effectiveness nito? Paano kung, excuse kung may mga nakikinig na government official, paano kung galing siya sa China, di ba? May report na yung sa mga Europe countries, binalik nila yung mga PPEs na galing sa China kasi defective daw. So paano kung natapat ka dun sa defective na PPE? So kung nag-fail yung PPE, malaki yung chance na ma-infect ka. So kaya nai-infect yung mga healthcare workers natin. Hindi lang dahil nagkamali sila. Kasi nandun din yung ano ba yung quality ng PPE na ginagamit nila. So dito sa Philippines, kung government hospital ka facility, di ba, pure procurement law. So lowest bidders win. So nag-equate ba yung lowest bidder sa high quality ng equipment na ginagamit? So yan yung isang malaking problem sa system natin ngayon na yung lowest bidder yung kailangan manalo. So hindi natin na-assure na tama ba yung quality ng PPE na ginagamit ng mga healthcare workers. At ang isang masaklap pa doon, compounding yung problem, walang capability yung mga lab natin para i-test yung validity ng mga PPEs na yon. Kasi hindi naman yun yung main function nila. Ang main function nila is to diagnose the patients at to test the samples. Hindi naman to perform a validation study.
Yeah.
I hope that answers the question.
Yeah, it goes back to yung recommendation kanina that we have built a culture in the lab na focused on quality of testing, but not focused so much on the safety aspect. So, yeah.
I think it's a good touch point dun sa next question kasi parang may tinanong tayo about how can we say that the current approved self-quarantine of 14 days is really enough to declare that the person is not infected with the virus? I think ang isang aspeto dyan na tinitingnan natin is yung ano yung itsura ng ating curve. Ayan. Kasi right now parang yung recommendations na binibigay natin based siya dun sa kung ano yung parang ine-estimate na bilang ng tao na makakakuha ng new infection, and of course bibilang ka ng 14 days doon, then after lalabas na yung symptoms. So parang, and of course madaling sabihin siya for one person, pero kung marami na yan, parang andun yung parang difficulty ngayon ng mga agencies natin like the IATF to decide if we will have to extend the quarantine. So, and of course, that also redounds to what will be the recommendations for self-quarantine. So, for the meantime, habang inaalam pa ng mga models natin kung kakailanganin natin ng extension for the ECQ, yun yung parang mandatory na we will have to have our self-quarantine for 14 days. That's actually just an arbitrary recommendation para at least we can somehow mitigate. Kumbaga parang sasabihin natin na at least for that 14 days, ito yung medyo sigurado tayo kasi na incubation period. So from a policy perspective, yun yung gusto muna nating magawa. But of course, it's also up to the individual risk assessment. Kasi kahit sabihin natin na 14 days yung incubation period, kung sasabihin naman natin na ay ang laki ng risk ng pasyente kasi health worker siya, di siya nag-PPE. So of course, higher yung risk niya. And therefore, there is a possibility na mas habaan niya yung kanyang self-quarantine. So may mga ganun din tayong considerations. You have to weigh what is the policy of 14 days versus what is the individual risk. Ayan. So kaya yung mga ganitong recommendations medyo hindi magandang sabihin natin siya na parang blanket statement kasi we have to really consider each and every person's risk. Ayan. Maybe my other yung ating other resource persons can add to that. Yes, please.
So dun sa recommendation, so katulad ng nabanggit ni Sir Jaifred, interim guidelines lang siya based dun sa available data na ginamit galing sa ibang bansa. So walang formal study na ginawa dito sa virus na to. Tapos nalilimutan natin lahat na kahit na around 4 months na tayo sa virus na to, it's still a novel virus. Bagong tuklas lang ito. Na ngayon lang walang data available kung saan ka makakapag-base ng mga decisions. So yung ginagamit natin is yung mga current available data. So para sa 14 days, so wala pa kasi nag-aaral ng serological study. So katulad dito sa Philippines, ka-approve lang ng IgM, IgG test kits. Wala pang ELISA. So kung meron sanang mga formal serological study, pwede natin i-correlate yung mga antigen at antibodies para makita natin, kunwari, kung mataas na yung IgG niya, wala ng IgM, tapos mababa yung antigen level ng virus, pwede na natin sabihin na convalescence na siya or parang meron siyang immunity towards the virus. So hindi lang tayo magbe-base dun sa average na 14 days incubation period para shed yung viral load. So I hope that answers that.
GR, you're on mute.
Sorry. So medyo mahaba na po yung usapan po natin tonight. So to close po yung ating session, I'll now call on Dr. Mike Kaampuen for some statement.
Ayun po, maraming salamat sa mga dumalo. So, in behalf of PSPHP, we would like to thank Sir Edsel Salonga of NTCBV and NIH, and then also Doc Jaifred Lopez of UPCPH, and Ms. Kim Sales of IHO, Alliance for Improving Health Outcomes. So maraming salamat for indulging us for another session kasi this session was very much wanted by a lot of people. Before, we had 150 plus sign-ups for this one. And up till now, ayun po, kanina medyo mas marami, no? It's sad to see na medyo nabawasan lang ng konti yung participants, pero ang ganda nung naging discussions, ng discussion afterwards. And yeah, I think this biosafety session points to for PSPHP's interest for everybody to kind of like link together and have a broader understanding of the situation. And it's our way of creating platforms for collaboration and, of course, community of ideas and understanding. So, I think with this lecture, sa akin yung isa sa mga nakikita ko, it's very important to have a systems view in a lot of things. Nandun na nga yung pag-respond natin sa COVID, where if hospital-based lang ang basihan natin, nakakalimutan natin ang frontline ay communities. Ganun din sa biosafety. That is not, the narrative is not just about PPEs and also laboratories, but also we look at enabling factors, facilities, anything that could break that biological integrity. And we have to make sure at whatever level of responsibility, inaalagaan natin yung integrity of our biological samples and also environment. So yon, sana all of us will become knowledge managers and share the information that was given to us. And we thank you all for your time, PSPHP, together with nandiyan si Doc Lester Heroy, and also our teams. Thank you, Doc GR and also Cristel, for facilitating and joining us in this session. So may I give it back to GR? Salamat po.